network very similar to how Netflix trains their models to predict what movies somebody would potentially like. Because these people have watched that movie, this might be a movie that you would also like. So we've used a very similar approach called matrix factorization, where we predicted these are the trials and this is how they perform. So therefore, these are the trial sites and this is how they perform. So therefore, we might, for this new study, select these given trial sites because they would most likely produce a similar effect. We've also combined this with an autoencoder to essentially reduce the dimensionality. What that means is, I don't know how technical you are. If you're very technical, then time me out. So, but essentially to extract really the core principles of the data so that we can ensure that the data truly understands it. So an autoencoder basically compresses the information to its essence, and then we unfold it again, and that's how we train it to make sure that it really understands the underlying principles. So we combined these two and had really good results. The way we validated that this was correct is that we can actually predict which trial sites from historical data that we haven't used performed well, and they indeed did perform well. And likewise, we identified several trial sites that human experts in our company have also selected for whatever complex rationale they have done this. This model did it as well. So that was pretty encouraging. Another area where we're working currently is composite models in clinical development. So what that means is that we build all these models for separate questions, like for genetics, for respiratory compliance, et cetera, and then combine them into supermodels. As a principle, what we divided our data inputs into is spatial, non-spatial, or static and dynamic. Dynamic means, do we have a time series of that data, or do we just have one snapshot? And so based on that, we select the different network types. So for example, for spatial and static data, which would be image, for example, we would use convolutional neural networks to train the model on. If, however, we have a time series of images, for example, we would use an LSTM in combination with the CNN. So this is basically our recipe model of how we selected different algorithms or different model types to train. And then we combine them all with one NLP to build these supermodels of models. So here's a typical example where we've used RNA-seq data, personal data, pathology data, clinical and radiology data, and applied the principles that I've shown you on the previous slide to create the models. And then we used integration subnets to actually integrate the output of these models into a more complex result or prediction. When we've done this for a given study that we conducted, we wanted to see which of the different labels that we've used or which of the different features that we've used had the most positive impact or the most negative impact. And for LDH, for example, we knew that had a very negative correlation, so that was very reassuring to see. On the other side, we had platelets, and specifically low platelet count, as a very positive indicator, so on the green side. And that was actually something that was very new to clinicians. They did not know about this. But if we use that as a predictor of how well a patient would respond to our chemotherapy, then that was actually very predictive. So here on the left, you see a phase 3 trial that actually we conducted. It was very expensive, and it failed. So this was a lot of money burned for no good reason, because it didn't create the statistical power to say that we have applied this particular chemotherapy to this particular group of patients, and it worked significantly better than if we hadn't applied this chemotherapy. However, if we selected this one feature and took only that subpopulation, and if we had designed our trial accordingly and only applied our chemotherapy to that subpopulation, then we would have seen a huge discrepancy between the application of our drug and a placebo. So that was very encouraging, but in order to validate that this was really true, we also used Flatiron. I don't know how familiar you are, but Flatiron has this huge data set. Our company bought it last year or 2 years ago. And so we took that data and said, okay, what if we only selected for the patients that also show this low platelet count? Would that actually, in fact, also indicate a high correlation to responding versus non-responding to our treatment? And sure enough, we could once again reproduce this really positive effect. So, of course, we took the result, gave it back to the clinical researchers. They're very excited about it, so this is still ongoing. In the interest of time, obviously there's many follow-ups that we can do. We can build predictive models. We can use transfer learning to actually take results in phase 1 trials and apply that to phase 2, et cetera, or predict phase 2 trial outcomes. And of course, subpopulation research, as I've indicated. So if you can identify a priori subpopulations of patients that would most likely benefit from this drug, well, then you don't really have to give this to patients where you would assume that it won't work that well. So maybe there's a much better therapy, because all of these have, of course, also side effects, and so you want to really maximize your likelihood that you're actually doing good to the patient. I mentioned earlier personalized cancer vaccines. What we've done here, so if you're not that familiar with this topic, in essence, what we want to train T cells, part of our immune system, to attack actually cancer cells. And the reason why cancer can grow out of control is because the immune system does not recognize cancer cells as anything foreign. So therefore, they're part of our body, and that's why they are left alone. Well, we want to use a molecule or a complex of molecules called MHC1, which is responsible for identifying mutated pieces of a protein or peptides and presents them on the surface to train the actual T cell to recognize it and weaponize that mutation. So what we basically have is, for given genomes, all the mutations in that cancer genome that are diverting from the healthy genome, and want to predict based on that data which of these different mutated peptides is actually presented on the surface of a cancer cell, and then which of these presented neopeptides is also recognized by the T cell. So those are the two steps. We have used data, and what we have done here is we have used models that are essentially borrowed from natural language processing. So they're so-called textual entailment. And what we do there is basically take a text, we take a hypothesis, and then we ask the question to the model, does this text T entail hypothesis H? In more practical terms, what it means is that we've used an LSTM, so long short-term memory model, in combination with a standard feed-forward neural network, and combined the output of these into multi-layer perceptron models that would either predict the peptide presentation or the peptide binding affinity. So those are two critical predictions of whether this particular molecule would actually be recognized by the immune system. The overall goal of this is, once you identify the molecules that are most likely to be presented on the surface and recognized by the T cell and then attacked, then you can actually synthesize those peptides, inject them into the body with some additional adjuvants, some additional drugs that simulate or boost the immune response and simulate basically an intrusion of some foreign pathogen. And that's how you convey to the immune system that, hey, there's like some virus coming in. The virus is actually not a virus, it's just the cancer. And so when the immune system gets sensitized and attacks every cell in the body that looks like our pathogen, which in fact is a cancer cell. So this is, I should actually include at some point images of before and after because they're so dramatic. There are some scans, or whole body scans, where you see kind of cancer cells all over the body, and then you apply this technology and they kind of melt away like ice cream in the sun. It's really amazing. So this is something that will come hopefully as a viable therapy. As input, we've used the peptide sequence and the MHC sequence to make it more personalized towards the particular patient. The outcome is there's a world standard or world-class level of predictability of 58%. Out of the gate, we have exceeded that to 71%. I believe right now ongoing we're kind of closer to 78%. So we're getting somewhere where we're increasing the likelihood of this methodology predicting which molecules to go after and which to use for cancer disease. Of course, what we're working on right now is transfer learning. So once we predict the first two steps in this, we want to extend this to a model that also uses the position of those mutations and basically predicts the immunogenicity. So this is like the holy grail in personalized cancer vaccine. If you can predict this reliably well, then you can have a really, really high outcome or a high likelihood that the patient will actually benefit from the drug. Let me see the time. Okay, I'm kind of running towards the end. Another project that we're working on is to use neural networks or deep learning networks, LSTM specifically, to identify what exactly is a cough. So you just heard one, but coughs can be very different. And instead of the patient, imagine an asthma patient that starts coughing irregularly, but then can we predict actually an imminent exacerbation? So we can automate this with some, even on a smartphone potentially, with some microphone, where we just trigger with a given cough signal, what is a cough, what is not a cough, and measure it, and then measure the distance of time, and then basically see or record the trend in this. So this would be enormously helpful because we could actually predict early on if a patient is getting worse, and if so, maybe initiate a visit to the doctor or to increase the medication, etc. Another one is lupus nephritis. So here we know already based on genome studies that there are 3 subcategories, and what we've used is, again, one of those combinatorial networks or composite network models to actually only use histology images, because that is something that we have for almost every patient, and predict those same 3 classes just on histology images. And we've had very, very good results on this. I believe lastly, we're working on patients on chips. So what this is that we use small organelles, small tissue pieces of human cells that all work together in an integrated system. So essentially simulate the patient, of course not one-to-one, but kind of, is there a correlation between a real patient going through some therapy and applying a drug to a chip with different organelles on it? And we're training imaging models to actually identify micro-phenotypical changes to map that to predict the outcome in a patient if that patient received that treatment. So we could potentially greatly expand our amount of patient cohorts just by supplementing it with a lot of chips. So as you can see here, we're covering a lot of different areas, and in general, I have divided this into 5 AI domains plus 1 more technology domain, which is like digital transformation, etc. So started from clinical AI to discovery AI, multimodal, where we combine composite models into one, imaging AI, and AI architecture, AI modalities, essentially AI methods into different domains where our researchers can work on. And with that, I believe I'm almost in time. I'm actually done. So. Okay. Okay. Yeah. So if you have any questions. What's that? Oh, wait.
What are some of the biggest pushbacks that you got from working with people that are less knowledgeable of this type of technology?
Yeah, initially it was definitely that people were worried about their jobs. So there was a lot of cultural change necessary because we were bringing in new technical folks that live AI on a daily basis. They know exactly what these mathematical models do and not do. And then you have, I don't want to say laymen, but they're employees that are experts in their domains, but not necessarily knowledgeable about AI. And all they feared essentially was that, you do this, and then next thing I know, I don't have a job anymore. So there was a lot of education necessary, and the best strategy there was really to help people become better at what they do. So there were always a few early adopters, and we worked with them very closely initially, showed them what we're doing, and when they actually improved their own performance in their jobs, that was a huge win. So that was definitely the earliest challenge.
Expanding on that a bit, can you comment on, maybe from the perspective of leadership at Genentech or Roche, what their view has been on adopting AI, and maybe broader than that, the industry, the biopharma industry as a whole? How does it view AI? And
so it depends on where you look from, right? So if you look from a tech perspective, we're like in the stone age. I mean, pharma is a very, very slow industry. Genentech is part of Roche, and Roche has been around for 145 years or something. So they're set in their ways in some ways. And they play it safe, and for good reason, because the last thing they want is to act quickly on something, and then it turns out it was not good for patients. So they're very conservative in that respect. Moreover, even if they wanted to, our pharma industry is federally regulated, highly regulated. So there's a lot of legal issues where you can't just do what you want, like in tech. So from that perspective, senior leadership can be was initially very cautious. That being said, the most senior leadership that I've talked to, and I've talked to pretty much all major CEOs of pharma, they're actually very, very open-minded towards AI. I think they believe this is the future to actually bring better drugs and faster. They don't like to wait 15 years for the next drug to hit the market. So how can we modernize in a meaningful way? There's a lot of openness on the highest level, that's for sure.
What do you think are some of the most important and underserved areas of AI in pharma?
Most important and underserved? Well, once again, the further downstream you go, meaning the further towards, I should do it this way, towards late stage, the more money is at risk, the more effort is at risk, and if one has even something that moves the needle a little bit, that can have an impact of hundreds of millions of dollars. Whereas early on, if you improve and find a new molecule that has potential, well, that's probably one of thousands that we are routinely scanning. So yeah, you could. So while everybody is currently focusing on the early stage, it's mostly because it's an easier task. So later stage, this is the general formula, that later stage clinical trials, clinics or clinical research is messy, biology is messy. So the more you have to deal with that, the harder it gets. The more you can go towards chemical structures, I don't want to say easier it gets, but the more predictable it gets.
Just more follow-up on this. So for the early stage, this drug is approved, what's the adoption rate like for the big pharmas? Let's say 50% of the drugs are phase 1 by AI or more than that?
So I think we use a lot of AI routinely, and we have been using machine learning, it's just more conservative machine learning for the past 10 years or so. But there's definitely an openness and open-mindedness and a willingness to apply data and to train models and to incorporate that and include it in our pipelines. So that's actually, those are the early adopters, to be quite frank. And I know that other companies are, they have really dedicated programs to include AI or deep learning into early drug discovery. So I'm aware of several companies that will do this. For us, we do it more if it fits the science. So the science is still the driver. But it depends on the company. Some are heavily betting on in silico drug discovery, and others are more on the science. But all of them use AI right now for drug discovery.
On late stages, like clinical trials, besides designing the clinical trials, what other goals the AI can?
Yeah. So, for example, as you know, the clinical trials are often conducted where you give half your patients randomly, to even the doctors don't know, you give them the treatment and the other half you give control. Which can be very cruel because if the drug actually works, you have like patients who volunteer to participate in the trial and they don't know, the administrating doctors don't know that they're on the control side. So, but technically for statistical purposes, you need a control arm. So we, and probably other companies too, we work on actually potentially life-saving drugs. So these are not simple things. So we're very heavily invested in oncology, so cancer drugs, etc. And if something indicates that it really works, we would like to have all trial participants benefit from that, of course. So we're working, for example, to develop control arms that are synthetic. So that can we develop models that select from a larger set of patients that have been in previous trials that fit the criteria, and can we pull them in and create a synthetic, basically control arm that never existed, but just out of synthetic data, so that we can spare. It's also a cost-saving factor in addition. I mean, that's a nice benefit. But it's really more to kind of avoid having patients go through all of the stress of being in a trial and then not really benefit, not having even the chance of benefiting. So synthetic control arms. Other areas are adverse effects. So for example, you can conduct a clinical trial and wait until the end, and then you realize, oops, we could have detected after 3 weeks that we probably should have stopped something because a certain percentage reacts really, really terribly to this drug. Well, wouldn't it be better if we detected that instantly, in real time? So if the trend shows where we can be detected, AI can actually pick up on these things. So they can sometimes pick up on really small nuances in changes of patient behavior that clinicians or we wouldn't at all. But if you have models in place that constantly scan the development of a clinical trial and can just raise the red flags, hey, there might be something off here, that would be great to, I mean, we'd rather stop the trial and save people's lives or make sure that they're not harmed in any way than continue it and then find out afterwards, we shouldn't have done this, you know? So there's many applications that also. Any other questions? Okay, well, thank you very much.